So this lecture is basically showcasing a lot of applications for circular external fixation, not just cable transport, which has been my thing for the past couple of years, but some other applications. And so, let's see. Not letting me advance yet. There we go. So external fixators come in a lot of different varieties, right? So here you're used to your trauma application here, just a uniplanar external fixator. Here we get a little more complicated where we have these linear struts. It's just a holding frame. Then we have a hexapod, and then we have an automatic hexapod. So various degrees of complexity, but different uses, all very powerful. And so here, traditionally people, this stuff was not taught in my residency. And like I said, I was taught fractures like to heal with compression and compression only. And so the idea of an external fixator, which, has, relative stability, was just kind of hearsay. But, you'd think it would not be within the AO principles, but if you take a closer look, the Elizaravian principles are the same as AO principles. And so, based in 1960s restoration of anatomy, you can control the anatomy with the frame, stable fracture fixation. These frames can be extremely stable to the point where, most of my frames are fully weight bearing. Preservation of blood supply. I mean, this is all minimally invasive, right? And so you're keeping the local blood supply and anatomy around the fracture or non-union site. And then early mobilization. Like I said, these frames can be built strong enough where they allow full weight bearing. So to me, this is very AO, and the AO over the last couple of years has finally caught on with more external fixation kind of courses and integrated into the resident curriculum. So, but all sorts of different applications, whether from traveling traction to holding frames, a frame to compress, and your frame will vary depending on what function you need it to do and kind of the local anatomy you're working with. So if you need to pull through a stiff non-union, you're going to have a lot more power and fixation than just a simple holding frame for an acute fracture. So here's a case, very simple external fixator, but used a ring for some specific reasons. So this is a 36-year-old male motorcycle accident. He had this open wound which was temporized, and then his skin just over a week's time is necrotic and died. But this is how he showed up to my clinic with a simple kind of trauma X-fix. For me, in my practice, my plastic surgery support is not very robust, and so I know this frame in my practice is going to be on for a long time. And so this is his initial, this is his clinic films in my clinic. And then, so I converted him to kind of this simple frame. The bar, the transcalcaneal pins are going to erode through the calcaneus fairly quickly. So I often convert to a thin wire frame if they're going to be prolonged. But this is a nice, even a ringed external fixator allows very good access to this wound. And so if there's going to be an external fixator on for longer than 3-4 weeks, I'm converting them to a thin wire frame, at least in the distal portion. You can still fix to half pins directly through carbon fiber rods if you need, but this guy needed a little extra stability and I wanted to control if I needed to add length. And so I put these quote unquote trauma struts on. So that's just one example of kind of a simple ringed external fixator. Here's another case, acute trauma, pedestrian versus auto. He developed compartment syndrome, was seen by one of my trauma partners who's very good, but had severe blistering. You can see his fasciotomy. He's going to be swollen, and with his injury, which is simple intra-articular, but still intra-articular, I think this was a good case to do a frame while things kind of calm down. I'm early to convert to internal fixation, but even a nail would be a little aggressive in this for me. And so we put him in a simple, we did fragment-specific fixation of his articular surface there, just percutaneous through small incisions. And then we applied this hexapod frame. And what this allows us to do is hold things in place and actually manipulate. We can reduce that fracture after surgery to get good healing and good opposition while his soft tissue improves. Could we have left this on for 3-4 months and potentially let the bone heal? Yes, but after 6 weeks, we converted into internal fixation. And so we put a lag screw across that oblique fracture, and then we were able to do delayed primary closure, so he did not need any skin flaps or skin grafts either. And so here he is 6 months from his initial injury, and he's walking, he's closed, and he's healed. So no pain. So, all right, let's keep upgrading. So in the deformity world, here was referred by my total joint colleague who said, I can't do a total knee in this patient despite his arthritis. 75-year-old had a fracture when he was 12, treated in a cast, but has progressive knee pain and instability. So for this case, he had extensive recurvatum deformity with translation in the setting of arthritis. For us, it's hard to do an acute total knee, and so the goal was to get him into the range of where a total knee would be appropriate. So in a 75-year-old, doing distraction osteogenesis is a little spicy, but we did it anyway. So here we are, we apply his frame, we fix his syndesmosis, make our osteotomy right at the apex, and granted we went very slow, but we were able to correct him to a point where he was growing new bone. He had better anatomy to fit a total knee. And so, but the name of this game is slow to create that new bone. So after the frame was off, tenuous bone growth, but that would continue to consolidate. And so we sent him back to his arthroplasty surgeon, who did a stemmed but relatively straightforward total knee arthroplasty. So no infection, no augments, a simple stem to protect things, but he's back walking and now needs a total knee on his contralateral side. All right, here we go. This is getting even more advanced. So 38-year-old infected pilon. This is how he showed up to my clinic. Osteomyelitis here. Had prior infection, hardware removal. Prior surgeon cleaned him out, but he was still draining. Had an open wound too. And so we attempted a masque-a-lay. It's like, all right, we'll try. It's supposed to work. Distal tibias are hard, but he was young, healthy otherwise. Okay soft tissue envelope, but we put a spacer in for 6 weeks, then went back in, did some iliac crest bone grafts and allograft. But this frame, like I said, very powerful. He's weight bearers tolerated throughout this process. Walking with a cane because there's some height differences, but overall, pain very reasonable. But anyway, he ate through his graft, and so failed, and so we had to do a bigger resection, and then this is where we started to transport. So like I showed you before, this is a trifocal. We'd set this up as a trifocal. Advantage of that, you can close that gap twice as fast. And so here is a very traditional technique as described by Quinnen. This segment here is going to move at 1 times down. It goes down and out the skin here. This one here goes down and around, and it's a series of pulleys that makes all set up to this motorized unit. So this ring is going to move up. It's going to tension the cables around and pull down to fill in the gap. So we automate it. So that's what that looks like. Not too complex. And here's that describing. So this segment goes down, 1x the speed. So every millimeter this moves up, this is going to move down a millimeter. And this segment here is going to move down 2 millimeters. And so here he is in transition. Here he is docked. Auto struts are designed to stall out. And so you're getting good compression. And I'll leave them compressed for a little bit. I was a little nervous just because of his docking site, and this is one of the earlier cases I did. So I put some tension wires over the remaining one after I nailed. Stabilized the intercalary segment here through a custom screw hole, and here just through the distal interlock. But here he is walking. Probably doesn't need the crutches. And here he is later, consolidating, and he's healed. Perfect. I think that's it for that lecture. Perfect timing. Happy to answer any questions at the end of this session or upstairs. So.
At the end. Bajar la pregunta para el final.